Good evening and welcome to Feet Forward. My name is Chris Martin. I'm with the Illinois Podiatric Medical Association, and tonight's guest is Dr. Khalid Husain,
Thank you.
who's a limb preservation specialist, a podiatrist, a doctor of podiatric medicine from the northwest suburbs. And his appearance here is kind of timely. I'm gonna pull up a little overhead for you guys because you might have seen this this logo making the rounds today in Chicago. The American Diabetic Association has designated today an Action Alert Day to raise awareness of the signs and symptoms of diabetes. And tonight's show, we're going to talk about the more acute phase of diabetes and how it affects foot health, specifically limb preservation and foot ulcers. So keep an eye out for the American Diabetes Association logo. If you see it, or if you could see it online perhaps, there's a risk factor test you can take to see what your risk is. And there are also some tips on how to prevent and treat it if you are not already seeing a physician for diabetes. Now, as a podiatrist, you often do treat or diagnose, do the initial diagnosis of patients with diabetes, don't you?
Yes, I do.
That's very common.
Yeah.
And what are some of the common symptoms you see in your office?
Some of the things we do see with diabetics is they'll come in with just complaints of bad toenails, tingling, burning, and then they're told by their primary care physician to come see us and have their feet checked out by the podiatrist around the neighborhood. So usually we'll get referrals from the local doctors in our neighborhood, and we'll assess them. We'll do a thorough foot examination, a thorough medical history, and then we'll discuss the findings with them, and then we'll go through a treatment plan and carry that out.
Okay. We have our first caller right away. This is like a Feet Forward record. Go ahead. You're on Feet Forward. How can we help you?
Hello?
Hello. You're on Feet Forward.
Yes. First, I wanted to say thank you for your time and your consideration.
You're welcome. How can we help you?
And well, my question was, you two guys just look like a bunch of.
The perils of live TV. That's the way it goes. But you were talking about some of the signs and symptoms that you see in your office a lot.
Yeah. So some of the signs, like again, the biggest complaint we'll see with the diabetic patient is neuropathy. And neuropathy is when you have nerve damage going on in the lower extremities. After a few years, with poor sugar control or with even tight sugar control, patients can develop neuropathy. And some of the signs and symptoms are burning, tingling, numbness, shooting pains, cramping, pins and needles feeling. And sometimes it can be very mild, or sometimes it can be very severe, where the patient cannot sleep and they're suffering, and they're asking for help from their physician.
And you sometimes will refer a patient to an endocrinologist, an internal medicine physician, or a family physician for overall care. And then you're also a part of that multidisciplinary team too, right?
Yeah, we work as a team. You know, we'll get back to the primary care physician. We'll let their endocrinologist, or we'll refer them to an endocrinologist if necessary. We'll refer them to a neurologist if necessary, if the neuropathy is that bad. A vascular doctor is also another component of the team we utilize, or a interventional cardiologist. And that's one of the signs and symptoms I didn't discuss so far, but patients will show some circulation issues also, disorders, where they'll have cool feet, they'll have cramping in their muscles when they're trying to walk. Sometimes the circulation is so blocked up or damaged where they're not able to keep their feet up. They have to keep them down all the time. So when they're sleeping, they'll sleep in a chair or a recliner where they can hang their feet over the edges, and then they feel a lot better. So that's pretty extreme. And so we'll have the patients, again, get assessed, do some testing in the hospital or in your office, and then we'll send the patient out to the vascular specialist to get further treatments. And there are a lot of advancements in that area also, where we're doing a lot of interventional work, kind of like they do in cardiology for the heart, where we do angioplasties and stenting of the lower extremities. Sometimes they'll do something called an atherectomy. It's kind of like a roto-rooter, where they'll clean out the blockage. And thus the patients do a lot better. Their symptoms improve, and they're happy.
All right. Let's try another caller. Hi, you're on Feet Forward. Let's try again.
Hi, good evening. Yeah, I wanted to ask a question about gout.
Sure.
How is gout diagnosed? How is it treated? And what exactly is gout? And also, is gout affected by your high blood pressure?
Okay, well, gout Gout is a metabolic disease that develops, or a condition, and it's usually a cause of high uric acid in the body. And when your body normally has uric acid inside of it, now either there are two causes for the gout to develop. Either the body does not get rid of the uric acid properly, or you're taking in too much uric acid, usually through food. And some of the foods that can cause it, and there's a long list, but I'll give you some of them. Red meat, sardines, dark green vegetables, beer, red wine, cheese. These are some of your big offenders. Tomatoes also. So you got to look at the list of foods you're eating too. How is it diagnosed? It's diagnosed many ways. We do blood tests to keep it simple. If your blood levels are high for uric acid, then you've been diagnosed with gout. You look at some of the clinical signs for gout. Is there a lot of redness? Is there swelling? Usually it's very painful. The reason why it hits the feet so much is because the blood vessels in the feet are quite small, and then these little uric acid crystals, they get stuck down in the joints of the foot or both feet, whichever it may be, and you get a large inflammation, a significant inflammatory reaction, and you'll have pain, tender, and swelling and redness, like I stated.
Why don't you pull the model up so the viewers can see? Point to the areas where gout tends to affect the.
So this is a skeleton of the foot. You have 26 bones, and I'm going to flip over the foot to the big toe side. This is your big toe, and gout will usually hit the big toe joint. That's right where it's the right size for the crystals to get stuck. The blood flows down through the large arteries, and then it comes down here, and they get smaller and smaller, and then you get an inflammatory reaction. So that's how gout develops. Another way you can diagnose gout is to do a aspiration of the joint, and they'll look at the crystals under the microscope. If they do see crystals, that's a positive diagnosis. Another way they diagnose gout is also doing a urine test for 24 hours. So there's a lot of ways it can be treated. A lot of times this is done in conjunction with your primary care physician.
Are there medications that are effective?
There are many medications. There's colchicine, and there's some new medications on the market too that are effective in treating it. They're not generic yet, so it's still limited in use. Allopurinol is another medication. So there's about 3 or 4 on the market, and they're prescribed quite commonly by the PCPs out there and by the podiatrist as needed.
Okay, thanks for your call. So we were talking about diabetes. A lot of people don't know that there's about 33 million people with diabetes in the country right now. 7 million of those don't know they have it. So you are often in a good position to diagnose it. But of the people that do have it and who are in the acute stages, which means they've been treated, or perhaps the disease has progressed beyond the medical community's ability to treat it, or they've neglected the medications, or because they have neuropathy and they can't feel their feet, they don't check their feet as regularly as they need to. Those people can develop some more acute symptoms. And so let's talk a little bit about some of those. And you've got some innovative, unique, and pretty cool high-tech treatments for some of these disorders. Why don't you talk a little bit about that?
Well, let's kind of go through a quick physical exam we do for a diabetic, and then we get into the new advances. We normally would check their nerve function, doing a quick monofilament test. We'll check their pulses by palpating the feet and the legs. We'll look at their skin, making sure there's no cracked skin, no open wounds. We'll look at their nails. Nails are, as simple as it may be for the average person, for a diabetic, they can be quite dangerous. If they're trying to cut their toenails and they hurt themselves and they have poor circulation, it may lead to an infection or gangrene.
Let's take another caller. Sure. Sorry to interrupt, but you're on Feed Forward. Go ahead.
Hi. I'd like to know if you can talk about leaky gut syndrome.
I'm sorry, we didn't hear you that question, ma'am. Could you repeat that?
It's called leaky gut syndrome. I believe it's an autoimmune disease.
Leaky gut syndrome. Well, this is a foot program, so I think that's going to kind of be out of my realm,
Okay.
being a podiatrist, but I apologize.
Thank you. I'll listen anyway.
Okay, thank you.
Sorry, we couldn't help that caller.
No problem. So getting back to what I was saying, so we'll look at the skin and the nails. Nails are a big problem too, so you got to be careful with that. And that's something we do routinely, nail care, foot care, making sure there's no open wounds, etc. Now, getting on to some of the newer advances you were bringing up, there are some exciting things that we're looking at. I'm into limb salvage myself. I've done a fellowship in diabetic limb salvage out of the University of Texas, and with that I brought to Chicago my training and, let's say, call expertise also. And we're in the business of limb preservation or limb salvage. Usually diabetics, when their skin breaks down, they'll develop a diabetic ulceration. And I think we have a picture of a diabetic ulceration we could throw up there.
Let's see, right here.
And this is your typical wound. So this is someone's heel, and there's a little surgical instrument on the heel. They're applying a piece of graft. And we're using these high-tech grafts these days, and this graft is from a human source. And we could talk about that in a second. I think he has a call.
Yeah, we've got a call now.
Yeah.
Okay, go ahead. You're on Feet Forward.
Hi, I wanted to know, if you're running, is it okay to run without socks, or would that cause a problem?
Good question. Very good question, especially now that the weather's warming up. Running without socks is probably a bad idea. I'm sure there's a few doctors that may say it's okay, but a majority of us will say it's not a good idea, and there's a good reason why. When you're running, you're going to perspire. And when you perspire, one of the things that can happen is you can develop blisters. And why do blisters develop? Because when the skin perspires, there's 2 layers in the skin, and the skin will want to shear. So those 2 layers will want to peel apart from each other or split apart. And if that happens, you're going to get a blister, or a bulla, we call it medically. And with that blister, you're going to have a lot of pain, and you're going to get an open sore, which also can lead to an infection. So then you're going to have to stop running. So if you wear socks, it will help wick the moisture away. And there are many good socks on the market. If you go look at the running stores, or if you go to a large sporting goods store, you'll see these special socks that have nice materials that help wick away moisture from the skin to help keep your skin dry. And that's the best way of keeping your feet healthy while you're running.
Okay, thank you.
Thanks for your call. And by the way, if you need a referral to a podiatrist in Chicago or in Illinois, for those of you who are watching on the live stream feed here, you could go to our website. That's www.ipma.net. Click on the Find a Physician button, enter your zip code, and you'll get 2 or 3 referrals of IPMA members near you. So you're talking about sores.
Yeah, so we're
and
talking
ulcers.
So we're talking about the new advances in limb salvage, and with diabetics especially. When we talk about limb salvage, it's generally referring to diabetics because they're the ones that have the circulation and the nerve damage.
Right.
So we're talking about the grafts. These grafts are interesting. There's new grafts on the market. Some names that come to mind are Dermagraft and Apligraft, Graft Jacket, Oasis. These are products. They come from bovine source or cow source, a porcine source or a pig source, and then of course human source. So a lot of the products we're using these days in the wound clinics where I'm working at are a multitude of grafts from all different sources. They take the graft from the animal tissue, they harvest it, they take it to the lab, and they process it.
Here's a little picture. I've got a little picture of a...
So this is a picture of another product.
Gives you an idea.
Apligraf, and it's in that
Right.
dish. So it comes with this nutrient-rich dish, and you take the graft, you lay it on in the clinic on an open sore, and with that open sore, you watch it over the next couple of weeks, and we've seen very good results with these products to help stimulate wound closure, especially in diabetics where we call them complex wounds. They do not want to heal for a multitude of reasons. Sometimes we get everything fixed, their circulation, we get them off their feet, but sometimes the wounds just do not want to cooperate. We lay some of the graft tissue on there, and we've seen very good results. And of course, this is all FDA approved, and the insurances are paying for it these days.
And about how long does a patient figure to wear sort of a cast or a bandage with after getting this treatment?
Usually these are done generally weekly. Sometimes they're done monthly. So it depends on the graft you're using. Every company has a different protocol for their product. But usually they're patient-friendly. It's not in the operating room most of the time. It's in the doctor's office or in a clinic, outpatient. No anesthesia is needed most of the time. So very friendly for the patients, and it's a big advance in limb salvage. Before we were just using gauze and ointments, and this is definitely high-tech medicine at its finest.
Cool. Interesting.
Yeah.
Now, the one I was really most interested in is the hyperbaric chamber,
Sure.
which you have some experience using.
Yeah.
And there's a lot of applications for it. Many people out there will be familiar with professional athletes use it, and as a horse racing lover, I know that a lot of trainers use it to heal horses, and it's been very effective across a wide spectrum of applications.
Right. I think we have a picture of a hyperbaric chamber.
We do.
So hyperbaric medicine is a big part of complex wound management and limb salvage these days too, and I am using it quite a bit with our patients. I work at 2 large wound centers at some of the local Chicagoland hospitals, and these hyperbaric chambers are located throughout Chicago. So, but what it's all about, hyperbaric medicine is oxygen at a high level, high concentration that's delivered in a chamber. And like you saw in that picture, that patient's laying there, and that chamber is pressured to 2.5 times atmosphere. So there's a lot of pressure inside. The patient does not feel it, however. And that's oxygen at 2.5 times normal atmospheric pressure. So what happens is they breathe it in. And once they breathe in that oxygen, their bloodstream has high levels or high concentrations of oxygen, and that's delivered to whatever part of the body that needs it. It goes down to the leg or to the foot in my patient's case, and they will stimulate new circulation formation and new tissue formation. Obviously, that's what we need for these wounds to close. So they go in every day, Monday through Friday. They get about 70 to 90 minutes of treatment. They could read a book, watch a movie, listen to music. It's very relaxing once they get used to it initially. And then they come out, they go home, they come back the next day. Now, these patients, they have to commit time. It is a time commitment, but if they're talking about saving their leg, it's worth the time usually, and they're very motivated. And we've seen very good results. Again, if this is FDA approved, insurances are paying for it, including Medicare. And it's been proven a highly effective treatment in salvaging complex wounds. So we're really excited about this. And again, I'd recommend patients out there, if they need help or they know someone else that needs help, to contact their local hospital. Either their hospital will have it or another hospital down the road may have it, and they can direct them the right way.
Is that therapy usually done with complementary or adjunctive care too, to speed along the therapy?
Well, when we're talking about complex wounds again, yes, you're going to not just do oxygen treatment. You're going to do the tissue grafts maybe. You're going to do offloading. Effective offloading is very important in these wounds. Usually diabetic wounds are on the bottom of the foot. So we're going to have the patient wear a special boot or a cast. The casts are especially designed to help take pressure off the wound, to help it heal. Or we're going to get them off their feet in general, like in crutches or a wheelchair. But there's many parts of it. And then revascularization is something I talked about earlier, but that's also very important. Diabetics, you're going to look at their circulation, make sure they're doing well, and optimize everything so they can heal properly. Nutrition and, again, tight sugar control are very important also.
And the podiatrist has a role in that multidisciplinary team to treat those patients with diabetes, and especially acute, sort of out of control runaway diabetes too, right?
Sure. I mean, diabetics might see these patients the most. Right now when I work at my wound center, I'm seeing these patients weekly, and a lot more than their primary care physician is. So I'll relay information as needed. I'll check up on the patient every time they come in. We're checking their vitals, their sugars. We're asking them questions. What are they doing about their health and their well-being? And then if there's a problem, we'll direct them to the right doctor, usually their family doctor.
And there's a lot at stake for these patients. They could lose either the entire foot and ankle, even upwards of part of the calf too, right?
Yeah, you know, one of the statistics we didn't really talk about is when a diabetic has an amputation of their foot or their leg, 3 years later, 50% of patients pass away. Yeah. It's because the long-term effects of having an amputation are not good on the body. It slows patients down, their hearts get weaker, and then everything else starts falling apart. Their kidneys don't do well, and next thing you know, again, 50% of patients, their bodies can't take it, and they pass away.
On the upside, patients that get podiatric care, their hospitalization, their amputation rate are reduced significantly, up to 85% almost,
85%,
right?
Again, yeah, we're the gatekeepers again, and we will be on top of what's going on with their feet. We try to keep an eye on them overall, their whole body and well-being, and then their feet. And if there's a problem, we'll direct them to the right doctor again, and the specialist as needed.
Now, you also had another technique that you used for charcot syndrome, right?
Yes.
That was rather unique, and I had not seen it before. And all the feet forward shows I've done, we've never gone that far. But I'm going to put up a picture of it,
sure,
because it was so interesting, and shows you how severe things can get for the diabetic patient that does not get proper care. So tell the viewers exactly what they're seeing here.
So here we have a picture of an external fixator on a skeleton. show you how it looks, but we actually put these on real patients, and this is a surgical application. So what's going on here is usually with a diabetic problem, you can develop charcot foot disease, and charcot joint can affect different parts of the body, but we see it a lot in the foot. And with the foot, what happens is the charcot patient, they have a lot of neuropathy, and the neuropathy is causing havoc in their lower extremity. They'll have circulation issues where the blood flow has increased too much. And with that increased blood flow, it weakens the bone. It basically leaches the calcium out of the bone, so their bones become softer. Then basically with all their body weight on the soft bones, their bones fracture apart. So they have a significant problem on their hands now. Their feet are fractured in multiple areas, and this is what we call charcot foot deformity. And usually you'll have a high arch, and if I show you the skeleton here, you know, when you have the skeleton, you could see the arch here on the bottom of the foot. But what happens is in the diabetic foot, the charcot foot, the arch will collapse and drop down because the bones have become soft. They can't hold the weight of the body. So we have a big problem. Their foots become dysfunctional. So we have to calm down the charcot joint disease by getting them in a cast or resting their foot in a boot for a month or two. Once that condition resolves, they still have the bones that have been deformed. And we have to go in there and then surgically realign the bones, straighten them out, and then we put the frame back on that we just showed you, the external fixator frame. And that allows the patient to heal the foot in a proper position. But the best thing about it is a lot of these patients can walk on their foot with the frame on, or they could use crutches at least to take part of the weight off. And this has helped a lot of patients where we'd put screws and plates, so we'd have to open up their foot extensively, and they did not do well. And there was a lot of failures, a lot of amputations that came about. But now with these new frames that have been going on, a lot more in the last 5 to 10 years, we've seen a lot more, we've seen more success, and we're quite happy with these results and the outcomes patients are seeing. So it's covered again. Insurance pays for this. It's approved by the FDA, etc. Yet it is a commitment also. The patient has to be ready to have a big surgery and wear this frame for 1 to 2 months.
That's about how long it takes typically?
Yeah, to get the foot to heal properly. Then we'll take it off, and they should have a nice foot after that, a functional foot.
And after that, that time period, how long does it take for them to get back and walking and daily activities and things like that?
Well, with these kind of problems like the charcot foot, which is a major problem, you know, the patient will have to go through rehabilitation once the frame comes off. They're not really allowed to do rehab with the frame on. They'll be sitting around the house or at a rehab center waiting for their foot to heal. And once it heals up, then we'll get the frame off. We'll send them to therapy for a few weeks. We'll let the therapist work with them, and then they'll be reporting back to the doctor routinely. And after about another month of therapy to 2 months, they'll get their strength back, and then we'll get them back into a specially designed shoe with maybe a small ankle brace or some type of brace built in with the shoe, and they'll do well. They should do well. The idea is to get them back on their feet walking. It may not be the same as before, but at least they haven't lost their leg and their foot is functioning in a way where they can walk.
That's great. We've got about a minute left of the show. Talk a little real quickly about the role podiatrists have played in reducing amputations, because that's one of the things that podiatrists are rightly proud of and can take a lot of credit for in terms of really achieving something major in terms of a major public health problem.
Right. Well, that's a very important point to bring up. Many people don't realize the role or the impact podiatrists have on the community and the healthcare community in general. We're working with diabetics. We're probably, when it comes to foot and ankle, the only people who are dealing with diabetic problems. And diabetes, with obesity on the rise in America, diabetes on the rise in America, there's obviously going to be a lot more foot problems, and kidney problems, eye problems, heart problems going on. So the podiatrists there's a shortage of podiatrists because of this. And we're there when the patients come in. We prevent foot problems before they become larger. If there is a big problem, we can handle it. We have the training to handle these problems, like I just showed you some of the modalities we're using now. So we keep the costs down by that. We're keeping it's a lot cheaper to save the leg than having a patient go on with an amputation, because they got to keep getting prosthetic limbs in the future. And they usually get disabled, they're not working, etc. So these are some examples how podiatrists fit in and help the patients and help our community in general. The impact is quite large.
That's great. Well, thank you for coming on. If you think you're at risk for diabetes, see your physician, make an appointment. If you need a podiatrist, call the 800 number on the screen there or the website, IPMA.net. There's a button on the website called Find a Physician. You can click on that, enter your zip code, and you'll get 2 or 3 referrals of podiatrists, just like Dr. Husain here, who will be available to meet with you and talk to you about your foot problems. Until next month, April 8th, that's April 18th. Feed Forward will be back. Thank you again for your time.
Thank you.
And if you need any questions answered, the IPMA is also on Facebook. You can search for us by typing in Illinois Podiatric Medical Association, and we hope that you will like our fan page too. Until next month, thanks again, and we'll see you then.
Thank you.